I'm Erin Ferranti, Board President for PCNA, and I'd like to welcome you to this episode of the Heart to Heart Nurses Podcast. PCNA is the proud home of cardiovascular nurses and one of the leading figures in the fight against cardiovascular disease. We have the resources you need for your day-to-day practice or to follow your passion to new areas of learning and growth.
I'd like to welcome our audience to today's episode where we have the great pleasure of speaking with Dr. Dharmesh Patel. And could you introduce yourself to our audience, please?
Morning, Geraldine. My name is Dharmesh Patel. I'm a preventive cardiologist practicing in Memphis, Tennessee. I'm a lipidologist with a focus on prevention. And I'm also the president of an advocacy alliance called PACH, which is a partnership to advance cardiovascular health. So very happy to be here, Geraldine.
Well, we know that you have a great affinity for and a lot of expertise discussing healthcare advocacy, and I'm hoping you could address that with our audience today.
Yes, I think my journey really begins about 10 years ago. And I think you probably will recall we had, the blockbuster therapies like PCSK9s, which came onto the scene. And I was extremely excited to be able to give my patients a therapy that could lower cholesterol by up to 60%. But as you well know, Geraldine, when you are in the patient's room now, there's not just two people in the room. There's you, the healthcare professional, the patient, but also the insurance company. And I hate to say it, but even as I practice today, I practice depending on the patient's insurance type, not on the disease they have, which I think really is quite poignant. And what happened is 2015 to 2018, I had patients who basically had LDLs greater than 190 or with genetic high cholesterol, or patients who had LDLs of, let's say, hundreds who had already had cardiac events. And I was excited to give therapies, but lo and behold, insurance companies would stop it or block the PCSK9 therapy. And I felt that was a real call to action for me. I felt that we had therapies that could really make a difference in patients' lives, yet they were not able to get groundbreaking scientific FDA-approved therapies. And for that reason, I really became a bit more involved in advocacy, because at the end of the day, the patients really have no voice. We are the patient's voice. And I'm so excited to be here at the PCNA because we all appreciate it's a team effort. And it's a known fact that patients and general public trust nurses, trust nurse practitioners way above any other profession in the country. So with that being said, I feel that being here is just another way to communicate how we as a team can really change policy. Because as you are well aware, there are many different barriers to healthcare access. We are all very, very familiar with barriers like prior authorizations, step therapy, co-pay accumulators, exclusion formularies, all ways of really putting barriers for us to help patients. Because at the end of the day, we all went into this profession really, I think, genuinely to make a difference in patients' lives. I don't think we were trained to fill out prior authorizations. And the sad fact is the average clinic in the United States, the average person in the office spends 13 hours a week on prior authorizations. That's essentially a full-time job. And I think there has been some changes, but I really do think that we have a very huge way to go. As you are probably aware, the government did introduce things like the Inflation Reduction Act. And a lot of people don't know what the Inflation Reduction Act, but it's a policy that was really predominantly in the healthcare sector to reduce the price of therapy. Now, I think that's very important, but there's always two sides to a story. For example, 5 of the 10 IRA therapies were cardiovascular medicines. And I think it's important because we want our patients to get therapy. So there has been some negotiating with the government and industry to make these therapies more affordable. They've made them fixed. Now, that's important. And so are things like, the fact that insulin now is only $35 per unit for patients. These are very good things, just like the Medicare caps are $2,000 for patients if they have a catastrophic event. And I think those are really, really important things. And I commend those movements. But please also understand on the flip side, as healthcare professionals, we are always looking for evolving science and new therapies in cardiovascular arena. Industry will, I think, appreciate the fact that, with Inflation Reduction Act, the bottom line is, as much as healthcare is important and access to care, I think money matters. And as a result, the Inflation Reduction Act can also have unintended consequences. For example, if the cost of therapy is less, then maybe, who knows, if prior authorizations, exclusion therapies will become more and more pronounced in the cardiovascular arena. We don't know that yet. We also don't know the fact that, with the Inflation Reduction Act, genetically treated therapies will be reduced in their patency life from 11 to 7 years. So therapies or companies that have been making blockbusting therapies may realize it's not, quote, so cost effective anymore to put millions and millions of dollars into cardiovascular outcomes when the lifespan of the therapeutic could be 7 years. So these are things that are interesting. It's a dynamic conversation. We don't exactly know where this will end up. But, I think it's really important to understand some of the nuances and forces that we have when we talk about advocacy. Now, on the flip side, as people in the, quote, trenches, we have made a difference. For example, with step therapy, we know that there are 140,000 patients affected with step therapy when one DOAC was changed to another DOAC. And, as you probably would be aware, lots of patients were confused. They didn't take their therapy, increased the risk of strokes. And, the PACH organization, the Partnership Advance Cardiovascular Health, really helped be that advocate for the patient. And we reversed 140,000 lives on step therapy, and the insurance company did retract and stop that. Other examples include, for example, PCSK9s in California. In 2020, one of the biggest insurance carriers in California decided they will stop PCSK9s, period. And we fought that with some of our key opinion leaders, including members of the PCNA, sending a letter to the insurance company. And lo and behold, about 2 to 3 months later, that was reversed. Now, on the whole legislation side, we have made a lot of changes in terms of advocating, for example, about prior authorizations. And in 2022, a bill has come out talking about the fact that prior authorizations need to be more streamlined and responses need to be more efficient and quicker. So I think these are all things that we are doing to try to help, at the end of the day, the person that's voiceless, that's the patient. So I'm really excited that we have lots of things coming down the pipeline. There are things like the Mini Act, which is an act really to talk about, should some of these small molecules be given a higher half-life, or should I say, from 7 to 11 years. Please understand, Geraldine, that one thing we don't appreciate is that cardiovascular trials, they are generally more riskier, they take a lot longer, they are very expensive. And so if we were to stop what has made this country great, which I think is innovation, new therapeutic modalities in cardiovascular medicine, we also don't want to suffocate the science and the industry that has brought that great therapeutic advances to our patients. So there has to be a happy medium in there somewhere. For every action, there's always a reaction. So I think as long as we all appreciate these different things, I think that's key. Another one of my nuances is, I think healthcare professionals, people in general think that a lot of healthcare costs are driven by healthcare professionals and by industry. But please appreciate the fact that there's these people called pharmacy benefit managers, the middlemen, a group of people that basically are contracting therapies to our patients. And we do not need to forget that this is a huge industry with around $9.1 billion made in 2020. Pharmacy benefit managers, I do feel, incur unnecessary costs to the healthcare system. And fortunately, the Fair Trade Commission has looked into pharmacy benefit managers too, because 77% of all prescriptions are controlled by pharmacy benefit managers. And so I do think that it's no surprise that out of the top 7 Fortune 500 companies in the United States, 2 of them are healthcare companies. United and CVS are two of the top 7 companies in the country in terms of revenue and profitability. And it's kind of somewhat of a monopoly in my opinion. We have an insurance company that basically owns the pharmacies, or tells the pharmacies which therapies to give, and then they also own the patients, because the insurance plan is essentially a vertical monopoly, a silo that basically is made profitable from the top all the way to the bottom to the patient. So, I do think businesses should, of course, be profitable, but I do think that when we talk about healthcare costs and the amount of money that's wasted in healthcare, I do think there has to be some accountability for insurance companies, and they cannot be bigger than, let's say, the Fords or the Googles for no reason. So I really feel, it's important. I think recently the Wall Street Journal talked about the fact there's been over 1 million denials for patients by healthcare insurance companies. And I think, this doesn't need to be this complicated. I think these are purposeful barriers so that our patients don't get the therapy that they need.
I am very grateful to you for providing that well-rounded view of what it's like to be a healthcare professional in today's marketplace. And it literally is a marketplace. And I can only imagine how complex it is when a patient comes in. You are using that lens of insurance coverage to determine what therapies to provide to them. You write a script, they take it to the pharmacy, and they may or may not be able to fill it for a variety of reasons. They get confused. They might not fill it. So even your best intention in that clinical setting doesn't necessarily result in that. Even that one therapy that you have determined is of benefit to the patient, maybe not the best benefit because it's not going to be covered by their insurance. There still are barriers. And so I think you are astute in noticing that patients are very confused. They do feel a little lost. They don't understand why they can't get the medicines that they hear about, or that you've talked about, or that they think that they need, or they've researched, or their provider has said. And I think the other issue is that when they have to change insurance, maybe they've changed jobs and the therapy that they've been on now for however long now is no longer covered. So there's a lot of transitions that I think are unnecessary, in my personal opinion, that really put additional barriers on those patients. So I applaud PACH for what you're trying to do in terms of leveling the playing field to ensure that patients do get the access to the medications and the treatments that they need. So you're a great partner with PCNA in terms of trying to educate individuals, be they nurses or other healthcare professionals, as well as patients, in terms of what's happening and what can be done, what potentially could be said. So thank you for doing that as well.
Thank you, Geraldine. To your point, when we give the prescription to the patient, let's talk about what happens next. A lot of the times, patients don't get that therapy because of prior authorization, costs, etc. So let's be honest. If I give the therapy that I think is the right choice for the patient, then I don't know what happens. And the reality is we have about a third of patients not getting their therapy. Can you imagine what the patient thinks? This healthcare professional gave me a medicine and he doesn't even understand that I can't afford it, or it's not indicated or approved by my insurance. And a lot of the time, the fact is they just don't get the therapy. And we don't know because we don't follow up with them. And so I think there really needs to be an easier, streamlined process for our patients at the end of the day.
Yes, that prior authorization process has put up a big roadblock for many of our patients and many of our providers. As you've discussed, it does take a lot of time to fill out that paperwork, be that electronic or in person, whatever it takes. So I think helping patients also, though, find their voice and to be partner with us in terms of helping to affect change is one of the strategies that I think PACH has encouraged us to use. And I think it's really valuable because I think when we work together, just like on therapies and treatments and patient outcomes, working together as a team with everyone involved, the more the merrier in this case, is my opinion.
Yeah. Well, thank you, Geraldine.
We are going to take a break and we will be right back.
For more education, resources, and tools for your clinical practice, visit pcna.net. You'll find CE courses, patient handouts, and more, all free to access. Visit pcna.net.
We're back with Dr. Patel talking about access to medications and treatments. And Dr. Patel, I know you work in a very specific part of the country where maybe there are additional barriers that some of us, no matter where we work, might be facing as well. And I'm wondering if you could address those for us.
Absolutely, Geraldine. I work in both the states of Tennessee and Mississippi. Some of the most obese, unhealthy states, unfortunately, in the country. And please remember, especially in Mississippi, we serve a very underserved rural community, especially a lot of Afro-American patients in particular in those areas. And I think that's really important because what we know is that healthcare access in certain parts of the country, like Mississippi, is immense in terms of barriers. And that could be due to so many different factors, including education, socioeconomic, literacy, housing even. And I think it's very important to appreciate that some of these patients have a different set of circumstances than we truly think. Some are living paycheck to paycheck. Some are not even sure where they're going to be living next month. But I think it's really important that we do bring advocacy to these areas because unfortunately these are areas where there has been no voice. So one of my personal missions has been to try to increase advocacy and awareness and access to care in quote rural deserts of Mississippi. And I think our group in particular has really made a stance and gone to areas which are very, very underserved, and we have clinics there now. So we're very pleased to do that. But what's important is that even access and insurance companies sometimes can be barriers to therapies for these patient populations, and we are working really hard to fight that. It's very sad to say that it's a fact. If you're, let's say, Afro-American, you're 20% less likely to be getting access to care of certain therapies. If you live in the southeast states of the United States, your likelihood of getting a prior authorization is 20% less than other parts of the country, just simply on your race or where you live, which is just not acceptable. So, I sometimes say the joke, if you have cardiovascular disease, don't live in Mississippi, because it's very, very difficult sometimes to get FDA-approved therapies to patients who need them. So we're fighting for this cause every single day, and I know that we'll make a difference.
Well, thank you so much for carrying the banner for us and leading us towards better access for all of our patients, no matter where we live.
Thank you.
Thanks so very much for being here. This is Geraldine Warfield, your host, and we will see you next time.
Thank you for listening to Heart to Heart Nurses. We invite you to visit pcna.net for clinical resources, continuing education, and much more.